We'll start this. So narrow versus wide, we had a brief discussion last time. So anything that comes down the normal conduction system because of by virtue of its fast conduction and also being in the center of the ventricular myocardial mass, it causes the narrow complex that is less than 120 milliseconds. So anything that doesn't follow this rule, that either because of the whole tachycardia is the ventricular activation is because in the ventricle or because of so many other reasons, it causes a wide complex. So you probably already know supraventricular tachycardia. So that's any tachycardia that arises above the AV node. If it conducts through the normal conduction system, it will produce a narrow complex tachycardia. So narrow complex tachycardia equates a supraventricular arrhythmia. Now, generally, a wide complex tachycardia also usually means it is a ventricular arrhythmia. That is, it's arising somewhere in the ventricle. But as we discussed last time, 20% of your wide complex tachycardias are actually SVTs, but because the way they conduct, because of the bundle branch blocks or because of pre-excitation, they produce a wide complex tachycardia. So the implication is that when you have a narrow complex tachycardia, we are sure that it's an SVT. The rhythm is entirely SVT. But whereas if it's a broad complex tachycardia, you're 80% likely that it's a ventricular arrhythmia, and it's about 20% chance that there's something else, either a supraventricular tachycardia leading to that. So that's exactly what we discussed last time when you have a broad complex tachycardia, how to differentiate between this and this. Whereas in the narrow complex tachycardia, we don't have that conundrum. We know that it is actually a supraventricular tachycardia. So you may say, yeah, if it's narrow complex, we just treat them all the same. Yes, most for medical treatment, it may not matter much, but it's good in terms of understanding the mechanism if we have to plan or refer them for a specific form of treatment, because individually each of them have different types of treatments and different success rates with the available therapies. Now, typically narrow complex tachycardia, we divide them into AV nodal repentant tachycardias. So that means AV node is an essential part of the circuit. The most common is you already know, that is the AV nodal reentrant tachycardia, where the circuit is part of the circuit is inside the node. So we call that a slow pathway. There is some slow conduction, and then there is something called a fast pathway, which goes up into the atrium, and then there is reentry within the AV node. So this is the AV nodal reentrant tachycardia. 85% of these narrow complex tachycardias are actually AV nodal reentrant tachycardia. Now, the second most common narrow complex tachycardia is something called AVRT, AV reentrant tachycardia, or orthodromic AV reentrant tachycardia. Ortho only means that it is going the right way along with the flow. That means normal conduction will happen through the His-Perkins system. During this tachycardia also, the activation should happen through this. That's the reason why it's producing a narrow complex tachycardia. But the retrograde limb is through a pathway, an accessory pathway, quite commonly on the left side. So it's atrium, AV node, ventricle, and goes up the pathway and into the atrium. The major difference between this is, if you have AV and RT, you cut out the atrium. Let's say, hypothetically, you cut out the atrium, this arrhythmia can still go on because atrium is not part of the circuit. Now you cut out the ventricle, theoretically, arrhythmia still will go on because ventricle is not part of the circuit. The whole circuit is within the AV node. Whereas here, atrium is an essential part of the circuit. If you cut out the atrium, the tachycardia, the circuit stops here. If you cut out the ventricle, the circuit stops here. So atria, ventricle, AV node, and the pathway are all obligatory components of the circuit. Now, again, this will help you in understanding why it behaves in certain ways, or ECG clues. So here in AVRT, you need to have atrium, ventricle, both are obligatory part of the circuit. Whereas in this particular scenario, the atrium and ventricle are not obligatory part of the circuit. So the other third, the least common of this is what we call as the atrial tachycardia, where there is a focus of atria somewhere where it most commonly is in some specific sites like crista or appendage or pulmonary vein. These are the common sites for atrial tachycardia. So it's a firing from that site, and it's just like sinus tachycardia. It's just that it's not arising at the same site as sinus node, and it behaves differently in terms of response to your autonomic tone. So these are the three common supraventricular tachycardias which produce narrow complex. But remember that all these three can also present as wide complex, because if they have a underlying bundle branch block or a rate related bundle branch block. But if they present with narrow complex, these are the most common tachycardias. Now, so 80 to 85% of these supraventricular tachycardias are narrow complex tachycardias are AVNRT. About 10 to 15 are the orthodromic AVRT. There is why I'm stressing on the term orthodromic AVRT. If you remember AVRT, that should be okay if AVRT is producing narrow complex. But there is something called antidromic AVRT, which is actually this circuit is reversed. It comes down the pathway and goes up the node. It's just the same circuit, but it is going in the other direction. So it is against the flow, against the normal flow. That's why it's called antidromic. So what does antidromic tachycardia produce? Does it present with narrow complex or wide complex? It has to produce wide complex because the activation of the ventricle is through the pathway, not through the normal conduction system. So antidromic tachycardia will present with a wide complex tachycardia. So it's not a differential diagnosis of a narrow complex tachycardia, whereas orthodromic AVRT is a differential diagnosis of a narrow complex tachycardia. But for practical purposes, you can remember that AVRT, most common form of AVRT is, or we call it short ORT, orthodromic reentrant tachycardia, instead of calling it AVRT and all that. So, and AT forms about 5%. So the most likely narrow complex tachycardia, which you will be seeing in ED or in the ward, is either this or this. Okay. Now, there are a group of tachycardias which are not typically called supraventricular tachycardias, but still produce a narrow complex tachycardia. One is, you all know, atrial fibrillation, because if the conduction happens through the normal conduction system, it produces narrow complex tachycardia. But the atrial activity is chaotic and produces very irregular narrow complex tachycardia. Now, then there is something called multifocal atrial tachycardia, which you sometimes see in COPD exacerbations, where instead of one single focus firing, there are multiple foci that are firing. Then the other example is what you call as an atrial flutter. So here again, it's a reentrant tachycardia involving only the atrium. Here the picture is not accurate, but it's only the atrium. Now, why these are not typically classified as supraventricular tachycardias, even though they produce narrow complex tachycardia, is one, the SVTs which we discussed typically happen as paroxysms. They are otherwise young, healthy individuals, just paroxysmal palpitations, you treat them in between that group. But these arrhythmias, one, they occur in older individuals. They're associated with structural heart disease. There should be some structural heart disease, atrial fibrillation, flutter, multifocal atrial. They are not seen in normal hearts generally. So associated with structural heart disease, and also because of this risk of stroke, thromboembolism, they're all completely different in terms of prognosis. So these are usually not grouped along with SVTs. So when you have a narrow complex tachycardia, these are all possible, but typically you can have paroxysmal SVTs, which are those three which I discussed. And these are the other three which present as either irregular SVTs, which have slightly different connotation. Okay. So when you encounter tachycardia with a narrow QRS, the first question you ask is whether it is regular or irregular. For the simple reason that these three tachycardias are regular tachycardias, whereas this and this, sometimes this as well, is actually irregular tachycardia. So the first question is it regular or irregular? If you are reading with a regular tachycardia, you are likely to be dealing with AVNRT, ORT, or AT. Sometimes flutter can also produce. Most of the times, actually, atrial flutter can produce a regular tachycardia. So when you have a regular tachycardia, it's one of these four tachycardias: AVNRT, AVRT, AT, or atrial flutter with some form of 2:1 conduction of this thing. When you have irregular, it's either atrial fibrillation or a multifocal atrial tachycardia. Multifocal tachycardia is rare, but you do see sometimes we see ECGs from especially pulmonary medicine where the patient is admitted with exacerbated COPD. Looks like a AF, but you can find distinct P waves with multiple foci. Now, once you decide that it's regular, the next question you ask is, that's not CAP, that's can P waves be identified? Okay, so can you see any clear-cut P waves? Okay, so sometimes it's very easy to differentiate, like in the wide complex tachycardia also, we thought we could see the ECG. Sometimes it is easy to identify, but sometimes we cannot identify it is. If we can see the P waves, what is the relationship between the P and the QRS? Is it 1:1 or is it something else? P's more than QRSs or QRS more than PVs, like in the wide complex tachycardia. Now, if P-QRS is 1:1, that is 1:1 tachycardia, what is the P wave timing in relation to the QRS? I'll go through this with ECG examples one by one. So these are the 4 questions you ask. Most of the times you'll be able to narrow down the diagnosis of the tachycardia. Now, as we discussed, these are the regular narrow complex tachycardias, all the 3 typical paroxysmal supraventricular tachycardias, and the atrial flutter will produce typically a regular narrow complex tachycardia. Can I just close this? So the irregular tachycardias are, as I already discussed, those 2. Yeah, and these are the regular irregular tachycardias. Now, so the first question, as I said, is P waves. Now, I'm not sure if you're able to see this. Now, this is a typical narrow complex tachycardia. Now, can you identify any P waves? So it's sometimes very difficult because P waves are 2 reasons. One, P waves you will not be able to see for technical reasons, like if the ECG quality is not that great, like the baseline wander is there, you see small glitches which you are not sure whether it's a P wave. That's one possibility. Or the P wave amplitude is small, so small, the QRS is so big, and then it just the amplitude is so small, you will not be able to identify. The other reason why the P wave may not be seen is P wave is inscribed within the QRS. So that means the P wave is there, it's reasonable amplitude, but it is P and QRS are overlapping. That's the reason why you are not able to see. So if there is no P wave, as I said, the first reason is a technical reason. It's there, but you're not able to see simply because of various other reasons. But more like it could be a physiological reason where you have AV nodal. The AV node is re-entry is happening within the AV node. Now the atrium and the ventricle are sort of activated parallelly. So typically what happens is atrium and ventricle are activated simultaneously. We call that A and V tachycardias. So when the atrium and ventricle are activated simultaneously, the P wave can be anywhere. Typically, it is buried in the QRS or just at the end of the QRS. So if you're not able to see the P wave, if you're reasonably sure that it's not P wave and you see a narrow complex tachycardia, that's very likely to be AV and RT. Of course, because you're not sure about the P wave, you can never be categorical about it. So if you don't see a P wave in a regular narrow complex tachycardia, no matter how hard you try, you're likely dealing with an AV and RT. You are 50% probability that it is actually, or more than 50%, it's AV and RT. The other reason being it's there, but you're not able to see because of technical reason. The second thing is this ECG. So like anything you want to comment on this ECG? It's a narrow complex tachycardia again. regular. Any telltale signs that this is more likely to be AV nut? Anything? P waves. I mean to say P waves. So always look for the beginning and the end of the QRS. Sometimes you may see waves that are not supposed to be there. And especially if you compare with the sinus rhythm P wave, you'll be able to better compare that. So for example, here you see that there is a small terminal glitch. Okay. Now, obviously, if you just see this ECG alone, you may not be able to identify. But let's say the same patient's sinus rhythm ECG. Okay. So now here you see at the end of the QRS, there is actually no wave. But here you can see actually the terminal wave. So similarly, you can see S wave and there is no in the sinus rhythm, but you can see a terminal S wave. So these are called pseudo R prime or pseudo S waves. So compared to sinus rhythm, it's not there. Obviously, S waves and R waves should not appear on the tachycardia. So when they appear, that means that it's actually a P wave that is just sort of terminal at the end of the QRS, it's buried and looking as if it's a R wave and a S wave. So we call this pseudo R or pseudo S. So look for this. If you have this pseudo R prime, this is called R prime because it's the second R wave. If you have this pseudo R prime, especially if it's not there during sinus rhythm, that means this A and V are simultaneously happening. Okay. So when you have a pseudo R prime, it is diagnostic of AVNRT. The reason I'll come to it. So in AVRT, you saw that the circuit is actually atrium, AV node, ventricle, pathway, and again atrium. So A and V cannot happen simultaneously. It's atrial activation followed by His-Parkinson system and the ventricular activation and then atrium. So they are activated in series. So P and QRS should always be one after another. But P and QRS are simultaneous, cannot happen with AVRT. So here, the implication is that if it is buried within the QRS at the terminal part or at the beginning, it's sometimes called pseudo Q. That means A and V are simultaneously activated. Then that means it cannot be AVRT. So for all practical purposes, it's a AVNRT. So if you don't see P waves, likely AVNRT. If you see pseudo R prime or pseudo S waves, almost diagnostic of AVNRT. So in fact, AVRT is ruled out because, as I discussed, this has to be sequential activation, whereas in AVNRT, A and V are parallelly activated. So this sequential activation usually means that it is not, AV is not, should, A and V cannot be together, buried in that. Okay. So these are the pseudo R prime or pseudo. Sometimes you can see at the beginning of the QRS, just it may give an impression that it's actually a pseudo Q wave. Obviously, when you see the tachycardia alone, you may not get an impression, but if you revert it and see, then you will get a better impression. Now, once you identify, let's say the P's and QRSs are clear. Now, try to identify what is the P to QRS relationship. So this ECG, what do you think? Can you see P waves here, or at least candidate P waves? I gave it up. So if you see, just choose a lead usually with a small T wave. That's where you're likely to see a P wave better. If you have a tall T wave, it's very unlikely that you'll see a P wave. Now, I would choose something like this or this for identifying these three leads rather than a bigger P wave, T waves like this, where it becomes difficult to identify P waves. Now, what do you think the P waves are here? So there are several potential candidates, right? So you can see that it's actually, and also whenever you see something that looks like a P wave, always put a calipers or just piece of paper and mark them out and see if they're following a pattern. Okay. So these are potential, these are happening at regular intervals. So these are seen. Also see, don't go by one lead, always come down and see across the leads. And in each lead, there is correspondingly, there is a small glitch or notch. So that is suggestive that it's very likely to be a P wave. Now you have these P waves, you identified the P waves. What's the relationship between P and QRS? So P's are more than QRS. So you see 1, 2, 3, 4 P waves, and there are only 2. So 2 to 1 conduction. So there are 4 P waves and there's just 2 waves. So what is ruled out if you have this the P-QRS relationship is not 1-to-1? Which of these SVTs is ruled out? So again, as I said, AV, NRT, that's the reason why I said that. So AV, RT, atrium and ventricle are obligatory parts of the circuit. If atrium is activated, the next ventricle has to be activated. If it doesn't activate, then it doesn't complete the circuit. So there is an obligatory 1-to-1 relationship between P and QRSs in AVRT. So if there is any relationship other than P and QRSs, it rules out AVRT. It is still possible for AVNRT to be there because sometimes the circuit is here. As I said, even if you cut out the atrium for some reason, let's say there is some block because of refractiness, you can have V's more than A's. Or if there is the His bundle goes into refractiness, it's not able to conduct at the rate at which tachycardia is happening. It's just conducting only 2-to-1. You can have it's going 1-to-1 to atrium, but not 1-to-1 to the ventricle. So you can have relationships that are not 1-to-1. Okay. But if you have a relation that's not 1-to-1, you can be sure that it's not AVRT. So if P's are more than QRSs, it usually means either it's an atrial tachycardia, or that means the whole driver is in the atrium, and it's just that it's not able to conduct 1-to-1. It's just his Perkins system is not able to conduct 1-to-1. So most likely, if it is P is more than QRS, it's likely to be atrial tachycardia or a atrial flutter. So you have P's more than Q's in a regular tachycardia, it's a flutter. Now the important thing is always look for this, because so many times you mistake atrial flutter for a supraventricular tachycardia. Okay. So if you find definitely P waves, sometimes the flutter may not give you the typical sawtooth appearance. It may have P waves that are slightly different from what you typically see. Always look for them. If you have P's more than A's, it's very likely to be atrial tachycardia or atrial flutter. The implication is, you know, that the treatment widely differs between AV NRT versus a flutter. Now, once you have the P wave and the QRS relationship 1-to-1, then you can classify it into what you call as a short RP or a long RP tachycardia. So this is the RR interval, right? And this is half of the RR interval. If the P wave falls in the first half of this RR interval, this is called the short RP tachycardia. If the P wave falls in the second half of the RR interval, this is called a long RP tachycardia. So if you have a short RP tachycardia, why do we classify this way? Is because we are trying to assign this P wave to this QRS. So somehow this P wave is related to this QRS. That's the implication. Whereas if P wave falls here, that may not always be true, but that's how we are thinking in terms of the. If you have a long RP, that is the P wave is falling in the second half of the RR interval, that means this P wave is likely to be related to this QRS. Okay. Now, what are the examples of this long RP tachycardia? The most common example. So this P wave is directly going. So it's just tachycardia and it's going QRS with a normal PR interval. Sinus tachycardia, right? So, I mean, it's not an SVT, but if something is going on like this, you always suspect it's a sinus tachycardia. You look at P wave morphology. Okay. Now, most SVT is present with what you call as a short RP tachycardia. The short RP tachycardia means this P wave is somehow related to this QRS. If that is the case, then what are your differential diagnoses? Most likely it's AVNRT. Somehow this P wave is related, but they're not happening simultaneously. Then AVRT is possible. So when you have a long RP, short RP tachycardia, AVNRT or AVRT. When you have a long RP tachycardia, of course, sinus tachycardia is not a tachycardia. The other differential diagnosis for a long RP tachycardia is, which looks like sinus tachycardia, but not occurring from the sinus tachycardia. I mean, sinus node. The mechanism, everything looks similar. It's atrial tachycardia. It's coming from a different focus. That's it. So if you want to classify, generally, there are multiple exceptions. I won't go into the details, but to remember, short RP is either AVNRT or AVRT. Whereas if it's a long RP tachycardia, it is likely to be atrial tachycardia if it's an SVT. right? If you have one-to-one relationship, this is the simplest way to remember. Short RP, you have a lot of algorithms even given in Harrison's where you go to the narrow complex. You declassify them into short RP or long RP. Short RP is AVRT or AVNRT, the first two, and the long RP is atrial tachycardia. So this is the simplest way. This I won't go into the exception. Okay. So yeah. So what do you think is this? Oh, sorry. So it's a narrow complex tachycardia. Again, go step by step. You have P waves. The potential can probably, it's slightly difficult, but I just pointed them out for you. Okay. So there are potential candidates for P wave. Again, I would look, say, I won't depend on one lead. I will just go up and see if there are correspondingly any P waves in other leads. I see P waves in other leads as well, especially here. You can see on the upstroke of the T wave, there is a small notch. So that is very likely to be a P wave. Now, what tachycardia would you call this? It's a short RP because this P is very close to this thing. And also you can see that the P is falling at the terminal of the QRS. So this, for all practical purposes, is actually AV NRT. So this is short RP tachycardia and it's a AV NRT. Now, what do you think this is? So here its P waves are much clearer. Okay, you can see clear-cut P waves here. Okay, and this is falling in the second half of the RR interval. So what tachycardia is this? It's a long RP tachycardia. So the best way to describe a narrow complex tachycardia is whether it's regular, irregular, and then a short RP or a long RP. So generally, when we say it's a regular long RP tachycardia. So when you have a long RP, as I said, most likely it is a atrial tachycardia. And also, if you see that the P wave morphology is very different from sinus. It's very quite pointed and skinny in V1. It's inverted in 2 and 3 and AVF. So this is not coming from the sinus node. So this is an atrial tachycardia. So what is this? This is technically not a narrow complex. It's borderline around 120 milliseconds. You may call it broad complex tachycardia, but still, let's say it's narrow complex. So can you see P waves? Yes, right. We'll go down that algorithm. You can see P waves, distinct P waves here, right? Now, the second question is, what's the relationship to the QRS to P? So what's the relationship? So yeah, so you're saying 2:1 because? That's good, but where do you think it is? This is P wave, that is P wave. Yeah, why are you able to see any P wave? I'm not really sure if it is seen. You're like expecting it, or probably it's buried, but you're not able to see the P wave right there. So still you may pass it off like 1:1. Now, if it is 1:1, let's say, what RP tachycardia is this? It's falling right in the middle, right? Just around that. So this is what actually you're right. So when you have this right in the middle, it's neither in the first half or the second half, right? And we call it, this is not official term, but we call it the mid RP tachycardia. The implication is that, as she was rightly pointing out, when you have a P wave right in the middle of the RR interval, always suspect that there is another P wave within the QRS, buried within the QRS. So we call this is a named rule called BIX rule. So when you have a mid RP tachycardia, always suspect that there is a P wave within the QRS. It's BIX, BIX. It's a eponymous name. So when you have a P wave right in the middle, so expect that, look for another P wave buried within the QRS. Now, usually if you carefully look at all the QRSs, you may find it. So for example, here, if you see in V1, the initial part is sort of slurred. And if you sort of use calipers and march them out, it in fact marches. So what you may pass it off as a 1:1 tachycardia is actually a 2:1 tachycardia. So this is actually atrial flutter with 2:1. So if you, the general, again, it's like a rule of thumb which we teach MBBS students is, if you have heart rate at 150 and mid RP tachycardia, for all practical purposes, it is atrial flutter with 2:1. one block, because typically atrial rate is around 300, the ventricular rate is around 150. So if you have a mid RP tachycardia, then the other P wave is buried within the QRS. So even if you don't see clear-cut flutter waves, it's actually atrial flutter with a 2 to 1 or atrial tachycardia. So yeah, I agree. All this is good, but like I would say 20% of the times in narrow complex tachycardia, you will not be able to make any diagnosis, reasonable diagnosis from the ECG. Now, we have an excellent tool where you use adenosine too. Probably you're already used to doing this. But I would suggest go through that, makes a readable diagnosis, and then give adenosine rather than just directly using adenosine. So when you give adenosine, what happens? What happens to AV-NRT? What happens to AV-RT? So what is adenosine? It blocks the AV node. So in AV-NRT and AV-RT, they are both, remember, they're obligatory node dependent. So they're node dependent tachycardia. So when something blocks the node, the tachycardia will terminate. So when you give adenosine and the tachycardia terminates, it is likely to be AV-NRT or AV-RT. Now, you cause the AV block, but you can see that the P waves are, the tachycardia is actually continuing. So this rules out either both AV-RT or AV-NRT. And this narrows down the possibilities to the other two. One is atrial tachycardia or atrial flutter, because in these two tachycardias, regular tachycardias, AV node is not an obligatory part of the circuit. Okay. So when you block the AV node, if it doesn't terminate, if it unmasks like this, then it is either atrial tachycardia or atrial flutter. One rule is you may encounter, probably may not encounter, but some of these atrial tachycardias are actually adenosine sensitive. So you give adenosine, not because they act on the AV node and block. Sometimes adenosine itself can terminate the tachycardia because they are sensitive to adenosine. So in that case, sometimes atrial tachycardias can also terminate with adenosine. But if you unmask like this is for sure not AV-RT or AV-NRT. So this has to be either atrial tachycardia or atrial flutter. You can use this same rule in broad complex tachycardias also, where the opposite happens. You give during a broad complex tachycardia, the V keeps going on, but there is a block from V to A. Then what is it? It cannot be a SVT with an aberrancy. It has to be a VT that is going backwards. It's just mechanistic thing. Yeah, this is just the overall how you approach narrow complex tachycardia, where it's regular, first thing. If it's irregular, the other two differential comes into picture. If it is regular, are the P waves seen? If the P waves are seen, what is the relationship between P and the QRS? And if then just differentiate between whether it is long RP or short RP, you will come to a differential diagnosis. Okay. Now, you may say, why do we need to differentiate at all? As I said, probably you don't have to differentiate between AV-NRT versus AV-RT. It doesn't matter for medical treatment, but it's important to differentiate atrial flutter versus atrial tachycardia versus these two tachycardias. The reason being the therapeutic implications are completely different. You anticoagulate a patient with a flutter, but you don't anticoagulate a patient with an SVT, right? The ablation success or the medical treatment for atrial tachycardia is not that great. Okay, I mean, it's good in the sense, but it's not as comparable to as the AV-NRT or AV-RT. So all these things come into picture. So I won't go into the details, just maybe a 1 minute briefly. I won't go into the treatment. So once you terminate, I won't go into this thing. So the long-term management, it's important that we have catheter ablation now, which is an excellent choice. Its success rate is close to 95 to 98% with very low complication rate. So generally what we do is, if you have a regular narrow complex tachycardia, if it is after conversion, you have pre-excitation, that means there is antegrade conduction. Some of these pathways do not conduct antegradely. We call them concealed pathways. But if you see pre-excitation, these patients are best for catheter ablation. It's always refer these patients for catheter ablation, even with the first episode, because medical treatment has a lot of side effects and it can cause some complications. But if you have no pre-excitation, that means you reverted the SVT with adenosine and there is no pre-excitation, all these three are possible. Then usually catheter ablation, but here you can try medical treatment. Just put them on beta blockers. But if you see pre-excitation, always remember that medical treatment is going to be ineffective and sometimes can be dangerous. Better to send for ablation. So pre-excitation with SVT, better for ablation. Other SVTs probably you can manage medically for few years. Yeah, I'll stop with that. So you can ask doubts, like we can discuss like last time also what we had. This can combine to, actually I was supposed to take this both together, but couldn't do that. There are no doubts, we'll stop it. The decreasing the rate, the yeah, there's something called double standardization with half the speed. So what you do is, these are called Lewis lead, and also you change the orientation. So what you can take is, it's cumbersome, but it can be done if you are really if like the diagnosis and the treatment is really dependent on that. What you can do is the lead one, the electrode, the lead one, typically you can shift so that you put that in the second intercostal space on the right side of the sternum and the right upper limb on the lower end of the like fourth intercostal space. So what it is essentially doing is only on the right side of the right atrial signals it's going to pick up. This whole lead you are going to localize to this. And you take it with a double standardization, double speed, then it can pick up P waves better. So that is what we call as a Louis lead. It's again an eponymous name based on Louis. You can do that but usually we don't do because adenosine is frequently available. We just give adenosine. But if you really think that that diagnosis is dependent, that you can do double standardization. You can see P waves better. Most often we don't do because it's easier to give adenosine than modifying that to put it there. But theoretically, and in the olden days when adenosine was not used so frequently, not available so frequently, they used to do this Louis lead. It's called double standardized, double, you gain up and put the shift this. You can just go back and read that. It's called Louis lead. Okay, end it. Thanks.